Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea. I serve as Dean of the School of Public Health at Washington University in St. Louis. I'm also the Editor-in-Chief of JAMA Health Forum, a peer-reviewed open-access online journal focused on health policy, healthcare systems, and population health, one of 12 specialty journals in the JAMA network. We are in a difficult moment for women's health. Threats to abortion access and disinvestment in public health organizations tasked with supporting women's health have created challenges and uncertainty. Cuts to global aid have placed women's health at risk around the world. Long-standing underrepresentation of women in research and lack of data about issues of core importance to women's health have only added to these challenges. I am delighted today to be joined by Professor Rosa Gonzalez-Guarda for a conversation about how we can address these challenges to shape a better approach to women's health. Professor Gonzalez-Guarda is professor of Duke University School of Nursing. Her research addresses health disparities and the intersection of HIV, intimate partner violence, substance abuse, and mental health among the Latino population. Her other roles include being previous chair of the board of directors of El Futuro, a community-based mental service organization that serves Spanish-speaking and uninsured immigrants in North Carolina, co-director of the Community Health Improvement Core of the NIH Collaboratory on Pragmatic Clinical Trials, and co-director of Nurse Leads, a training grant funded by the National Institutes of Nursing Research to support the scientific development of nurse scientists in developing nurse-led models of care to improve population health. Really pleased to be speaking with Professor Gonzalez-Guarda. Rosa, good day.
Good day. Thank you so much for the opportunity to be here with you and to talk about women's health.
Thank you. Thank you for joining. Let me start with just a foundational question. What do we mean when we talk about women's health? How should we define it?
I use an adapted version of the World Health Organization definition of health applied to women's health. So I think of women's health as the mental health, physical health, and social health and well-being of individuals identifying as women. In thinking about individuals identifying as women, I also think about the biopsychosocial aspects of womanhood. So what are the biological factors? People typically talk about sex. What are the social factors? Thinking about gender and knowing and recognizing that gender is very socially and contextually rooted. And then also thinking about politically what it means to be a woman. There's a lot of political determinants that I hope we get into in a bit that shape the experience of women and the access to decision-making, power, resources, and opportunities that can be resources to optimize health.
Thank you. I think that's a nice segue actually to my next question then. So let's talk about the challenges. So there are many challenges, but what would you say are the central challenges women's health faces in the US and globally?
I think one of the most fundamental issues in women's health has to do with women's rights and women's equity. And it was, in fact, thinking about women's rights when I was a young girl being raised in an immigrant family and seeing differences between ways that boys and girls were treated that really influenced my interest around women's health. So I think it's really important for us to think about what rights women have both here in the United States and globally that shape the opportunities that influence health. And I know right now there's a lot of focus on reproductive rights, which is really important. It's a critical issue around women's health. But there's other issues politically as well as the right that women have to vote. We only had that right in the 1920s here in the United States. The right to own land and home ownership. Here in the United States, women were only allowed to own a house on their own without a cosigner or a spouse in the 1970s. So that's pretty recent. The right of education. Some girls don't have opportunities for education globally. So all of these issues around women's rights shape women's resources and women's health. And one of the areas that I study, which has to do with gender-based violence and also HIV risk, is very much rooted on equity of women. And we know places in the globe where there's more inequities around women's rights. We also see a higher incidence and mortality around HIV and higher rates of intimate partner violence. So we know that's deeply rooted with women's health. Now that's a political social factor. One of the health factors or health consequences of that I'm very concerned with is maternal mortality. So I think that's another huge threat to women's health. I myself don't study maternal mortality. I have supported some junior scientists that have, but as someone who's interested in public health and population health globally, that is one of the most important indicators that we have of the well-being of a country. And it is unacceptable, I think, that we have such high rates of maternal mortality here in the United States and across the globe, where we know that about 80% of that is preventable. And that speaks to the investment or lack thereof in women's health. And then the last concern that I have is more of a social concern as well, that I see as a main threat to women's health, is the fact that right now we live in a very divided country. And despite globalization, where we're meant to be very close and connected, I am worried that women are not uniting in the ways that we should to advocate and to push forward, learn from each other, and advance women's health.
Thank you. That's a really nice summary. Let me move to a paper that you wrote, which I really liked in JAMA Health Forum recently with Professor Tammy Hernandez. And in that paper, there's this quote, which I'm going to read to you, which is, although overwhelming evidence supports that both sex and gender-based factors influence the health of women and also make them susceptible to deleterious health outcomes, women's health has historically been invisible. So talk us through, how have women been invisible in population health, and what are some historical examples of how women have been excluded from the work of health?
Thank you for looping back to that. I think the invisibility of women has to do with the autonomy of women in terms of leadership and decision making around what is studied around women's health, how it's studied, and what are the translational elements of the discovery that comes from women's health research. Some examples of this that speak to this lack of autonomy and power are atrocious examples in history around how women were used to advance women's health without consent. One of the most well-known examples of this is with who is known the founding father of OBGYN, Dr. James Marion Sims, and the experiments he conducted with enslaved Black women to test new procedures without their consent. At that time, Dr. James Sims believed that Black women didn't experience the same level of pain as other women and used that as a justification to develop new procedures that are used to found the OBGYN field. Another example of this, which is much less known, is the Puerto Rican pill experiment that was conducted in the 1950s, where Puerto Rican women were used in experiments as well, in trials to test new birth control pills without their consent. And that was part of a larger movement of the time that was part of a sterilization campaign that happened in Puerto Rico, where there was mass sterilization of Puerto Rican women without their consent. So these are all examples of ways research were conducted without the leadership of women as the investigators or informants or directing priority areas for research that were used to advance medicine, especially around medicine in the area of women's health, and that has had really deleterious consequences down the road. So now when you look at that example of maternal mortality as a key indicator of women's health, the groups in the United States that are among the most disproportionately affected are actually Black women and Puerto Rican women.
So let's talk about clinical trials today. Talk us through how women have been underrepresented in clinical trials and the implications of that. How has this lack of representation shaped the clinical guidelines that we currently use?
So historically, women have been excluded from clinical trials, especially early phase development drugs. And originally, the justification for that is that women of childbearing age in particular are biologically complex, right? Because of the physiology having to do with pregnancy. But also initially, the idea was to protect women and the fetus from potential harm of early phase clinical trials. But that had the negative impact of having trials to generate new discoveries on treatments, interventions that are on populations that are majority white male. And so the consequence of that is that we saw that the dosing, for example, of medications were not dosed correctly for women because they weren't part of the sample. And so there's a missed opportunity too in terms of generating new discoveries that would benefit women as much as they would benefit men, and had the unintended consequence of potentially producing harm among women. That early on rules around trying to protect women and fetus from harms from clinical trial, that has persisted over time. And it was only into 1993 where there was requirements that the FDA and NIH put to make sure that women were being represented in clinical trials. But when you look at representation even today, you'll see that women are still lagging in terms of the representation of clinical trials. And so this poses a challenge around scientific equity, making sure that advances in science are benefiting all populations and that people have the opportunity to benefit from those discoveries.
What do you think are the biggest data gaps in our understanding of women's health overall?
I think the biggest data gaps that exist in women's health has to do with the impact that policies, health policies and social policies more broadly, have on health outcomes. One of the reasons why I think that is a gap, I think those kinds of questions are more difficult to answer in terms of traditional designs, but also there hasn't been an investment in terms of studying those impacts of policies. So I see that as one area, a big gap. For example, how are limitations to reproductive decision-making impacting health outcomes, and what are the cost effectiveness of those policies? Another area I think that is lagging is, although we've described a lot of inequities within women's health as a group in general, but also within women in terms of different racial and ethnic minoritized populations, sexual and gender minoritized populations. Despite the fact that we know that there's vast inequities within the population, and there have been some interventions here and there that have shown improvements, we don't have a strong evidence base to really address those inequities and to scale those inequities through innovative programs and policies that are showing early promise of making a difference. So those are the two areas I think that are our biggest gaps that we need more data and evidence to drive decision-making around.
So let's talk about structural solutions for a second. So I'll go back to something you've written, and the quote you say, "It was not until 1993 that federal policies mandated the inclusion of women in clinical trials conducted by the NIH." So talk us through what role health institutions like the NIH can play in encouraging policies and practices that advance women's health, and maybe tie this in a little bit to the current challenges to these institutions and the potential threat that may have for women's health.
I have had the opportunity of being able to sit on study section for NIH for a number of years. And it's always been wonderful to see how new notices of special interest or new requirements, so for example, requirements of diversity and inclusion of women across the lifespan, how those really make an impact in terms of helping navigate investigators to put those issues as central in their proposals. The policies that NIH and other grant funders have really do drive the field. And I am very concerned right now that there is a pulling back on a focus on making sure women are included in clinical trials. I'm very concerned on top of that from an intersectionality perspective of considering other identities. I'm concerned about the pulling back of monitoring diversity in participation of clinical trials as well. And so I think structurally in terms of moving the field forward, we really do need to continue and make sure we center the inclusion of women and making sure there's diverse representation of women in clinical trials. There's also the other component of making sure that we have women representation as investigators and women representation as clinicians. We know when there's diverse perspectives at the decision-making table and there's the inclusion of the woman's perspective in decision-making, that we're more likely to have plans and centering and making sure that we're reaching those populations. So that's another area structurally I think it's important for us to continue to invest in to make sure that we maintain a diverse biomedical, clinical, and health workforce to lead women's health.
Let me take a thread from something you said, because you were talking about women's health intersecting with other areas. So you have in the past made the case for an intersectional approach to women's health. So for listeners who may not know, what is intersectionality? What does it mean in the context of women's health? And what are some barriers to intersectionality and how can they be overcome?
The way I defined it is having to do with different identities and experiences that we all have and how they come together to shape a unique experience, and how those unique experiences are more broadly shaped by interlocking systems that influence those systems. Often intersectionality is used within the context of trying to understand oppressed groups, and it's really helpful in informing approaches to make sure you reach and address the unique issues of oppressed groups. So I can give you an example. One area that I work in has to do with intimate partner violence. The risk and protective factors and the solutions to intimate partner violence really do need to be founded on an intersectional perspective. So being a woman is a risk factor to begin with because of the social context, the political context of what the experiences of women are. But then there's other identities that also need to be considered. So I can give the example of my own identity as a woman and also a Latina woman that shapes my unique experience with health, for example, particularly thinking about our political moment right now with the immigration context. But if you also add on another level of identity related to race, I'm more of a white passing Latina. If I was an Afro-Latina, and you add the experiences of Black women in our healthcare system to the experience of women in general, or to the experience of being an immigrant, that shapes a very unique experience with healthcare. So those are all perspectives that need to be considered. One of the challenges that has happened in women's health is that we have seen that improvements and movements around women's health have not always been inclusive of all those intersecting identities and have consequently ostracized certain groups because they haven't felt included. For example, we know the feminist movement here in the United States resulted in some lack of inclusion around Black women in particular, and that is some of the founding forces of the intersectional perspective that has helped us be more cognizant of those intersecting identities.
So let me shift a little bit to something else that you wrote, and I'm reading you again from your paper, which is the path forward requires addressing barriers to the engagement of diverse groups of women in research and investing in strategies developed for women that ensure that racial and ethnic minorities and sexual and gender minorities are not excluded. This engagement can only occur through specific strategies that center women's health broadly to include and intentionally name all who identify as women. So this builds a little bit on your point about intersectionality, but what would you say to the perspective that while it's important to embrace inclusivity with respect to all who identify as women, in the context of health, we should adhere to a narrower definition of women for the purpose of clinical work? So is there a tension between the project of expanding inclusivity in health and shaping approaches to women's health that reflect the unique experience and needs of cisgender women?
This is definitely a tension, I would say, a delicate one. So I think what is happening now in terms of a recognition that the women's health movement has not always been inclusive of all women. For example, women who identify as transgender women. In an effort to be more expansive in the women's health movement, we have started to not use women sometimes in clinical practice. So for example, a good example of this is the use of birthing people, which is a great and respectful way of recognizing that not all people who give birth, that is one experience that some women have, not all women, but not all people that give birth identify as women. So it's important to recognize that. And while we do that and make sure that we use language that is humanizing and is respectful to the identities people have, it's also important not to erase women from that effort. Some women have felt excluded when terms like birthing people are used and don't recognize I am a birthing person that also identifies as a woman. So there is a tension there. And I think when we're working with individuals, it's easier because when we're working with individuals, we can get to know individuals and understand the way that they identify and be respectful and responsive to those identities and our language and interactions with them. Where it becomes more difficult is when we're talking about groups and at a population health level where we're trying to be inclusive of multiple identities and being cautious of what words we use to make sure as many people are included in that effort as possible.
I feel like if we can have that kind of conversation about all these difficult issues, the public conversation would have a lot more light and a lot less heat. So thank you. Let me ask something now linked to the public moment. So you have written about language and its use in the moment, and in particular about the chilling of the use of the word women on federal funding applications under the current administration. Build on what you just told us. Why does language matter in the context of women's health, and why does a chilling of the use of women-centered language pose risks for women's health?
Language evokes our feelings towards people and the humanness of people. So historically, language has been used to dehumanize populations and decentralize and marginalize populations. So it's really important that we get this right. I recently wrote a paper with some colleagues around the use of the term illegal alien to talk about immigrants. The use of alien, foreigners, is a intentional language process to other and dehumanize people. When we dehumanize people in our language, it allows us to commit crimes and cause harm without feeling as bad because we are, through our language, subhumanizing people. And so that is something I think we can learn a lot from. Getting the terminology around women's health is really important, and speaking with the people that we're trying to partner with in the solutions to promote women's health is really helpful and important. And trying to generate words that evoke inclusiveness and that are a strategy to bring people together rather than to separate is something that's going to be very important. It's difficult because, as we've discussed around the intersectionality of identity, it's important for us to call out specifically the many different experiences, opportunities, subgroups have. That's fundamentally important in informing population health efforts. At the same time, we don't want to dissolve the base of women's health so that there's so much separation and difference that we're not able to find common ground and advocate for strategies that are helpful in improving health for the Women's Health Coalition more broadly.
So, a couple more questions. Tell us the way forward. What are the approaches that we should be taking to advance science and progress?
So I think the path forward is really important for us to think of women's autonomy and agency in decision making. Women need to be represented in leading policies, trials, setting the agenda for women's health and population health more broadly. So the politics of women in influential positions is really important. Their voices need to be heard, and the agenda needs to align with the priorities of women, the health issues they care about most, the things that are more central to their families and society. So I think that's one of the key elements of moving forward. Another, which is related, has to do with representation of women in clinical trials. We need to make sure that women are adequately participating in clinical trials and also leading as investigators clinical trials and other research that is driving population health around women's health. And then lastly, I think one of the themes in our conversation today is making sure that we don't lose our approach on intersectionality. There has been some great examples of investments on women's health, such as the Women's Health Initiative, which is something that we do reference as the path forward, an exemplar in the path forward in our JAMA article. But if there's not a close eye on intersectional identities and representation from that lens, we may move forward without important perspectives being at the table. For example, although the Women's Health Initiative has generated a large, enormous amount of data and evidence to drive decision making around women's health, particularly in the area of hormone therapy, the majority of the participants are still white women. Over 80% of participants are white women. We need to make sure that this intersectional perspective is at the table. We need to make sure racial and ethnic minoritized groups are adequately represented, that sexual and gender minoritized groups are adequately represented, so that we make sure that within this larger group of women that all populations are benefiting.
Let's take that and end on a last question of hope. In a time of tumult, and you've written about this for all of the health population and for women's health, what gives you hope?
What gives me hope is our junior investigators. They have a far more sophisticated way of thinking about intersectionality than many of us have been trained and exposed to in our development as scientists. And I have the hope that they're able, with that intersectional lens, to be able to bring together coalitions of women in a way that we haven't been able to in the past, to make sure that we continue to advance women's health in a way that is unified and that at the same time respects the differences within our group of women according to these different identities.
Thank you. I'm Sandro Galea. I've been speaking with Professor Rosa Gonzalez-Guarda. We've been speaking about challenges to women's health in this moment. You can find a link to articles by Rosa and by myself on this topic in today's episode description. Thank you, Rosa.
Thank you. Thank you for the opportunity to talk to you about this.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, jamahealthforum.com, or look for a JAMA Network wherever you get your podcasts. Thank you, everybody, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.